These community transformation grants are big stimulus dollars that the Centers for Disease Control was able to give out. And they were very selective. It was a competitive grant process. And Massachusetts, to its credit, I think was an easy pick, was an easy win when they were deciding who to give it to. It was fairly, and I know the folks at Centers for Disease Control because I actually am on a team of technical assistance providers that I work with communities all over the country, just like Medford, that are embarking down this path. It was easy for them to say yes to Massachusetts because the premise of the MASS program was to give this money out to the communities through what's called MASS in Motion. That's the little logo. We're sort of unique in making the effort in Massachusetts is to push this to the communities and let it be very much based on the creation of local community teams who select really what it is you need to work on. So it's not dictated by somewhere else at the national level. These are the 4 things you're going to work on. Quite the contrary. It's about what's going to happen here today. You guys setting priorities. My job is to sort of set the table, to tell you about where we think the science is around healthy communities, and then send you sort of stimulate thought. Why is it a health organization, Centers for Disease Control, is thinking about things like planning and zoning policies, and complete streets, and school nutrition, and transit and bicycle programs, okay? Because those are the tables, you know, the topics we're going to talk about. Second, I'm going to talk about where the bad news is from a public health standpoint. But basically it's this. What we've been doing hasn't worked. I want to make sure you understand why, because then you'll understand why. The good news is we do know what will work. And here's the hard news. It's really hard to do it. This is what we hear about. We have an obesity epidemic, right? This is the kind of data we're hearing. The graph on the left shows the percentage of American adults with a body mass index above 30 is rising. In fact, the curve is steepening. And we talk about our supersized kids. I'm not even impressed, by the way. I think, in fact, I would argue that the media coverage like this is not helping the conversation at all. We see that, indeed, the data looks like it's not only getting worse, but at an increasing rate. This is a fairly recent USA Today, just in May, that says all the projections say we are not making progress on the problem of obesity, and it's the wrong problem to talk about. I think it's well captured by this article just 2 weeks later in USA Today that talks about the fact that type 2 diabetes and its precursors, by the way, a disease we used to call adult onset diabetes. We used to think you couldn't get it till you were 40 years old. Does anybody here work in the medical field? Adult onset diabetes, right? That's what we call it. Now we have to use a clinical term, type 2, because
children have it.
We're seeing it in 8 and 9-year-olds, right? We didn't think it was physiologically possible. And indeed, the rates are going up at such a great speed that Dr. Larry Deed, the former medical director of the American Diabetes Association, says we are truly in deep trouble. Diabetes threatens to destroy the healthcare system because it is so costly to take care of. This special issue of Time magazine talked about the interventions that we've tried, talks about a very compelling a trial called the Diabetes Prevention Program. Different people all over the United States at different ages and incomes and ethnicities and income levels, education levels, but notably they were put in these 3 study groups, one of which got metformin, which is a diabetes drug, and another one which got an intensive lifestyle modification program. And strikingly, the people who got the drug saw a 30% reduction in risk of developing type 2 diabetes. Great news! 30% reduction in risk. We don't see that in medical trials, ever. 30%. The only reason it wasn't the big news was what? The guys in the lifestyle intervention saw almost twice the risk reduction. The people in the lifestyle. Now, let me be clear. All they did was get things like shopping and cooking classes, so they learned how to purchase and prepare much healthier food. And they got these 30 minutes of moderate physical activity every day. Let me be clear. They were not training for a marathon. They were going out and walking for half an hour, 5 or 6 days a week. Got it? That's what reduced the risk of developing type 2 diabetes by 60%. The reason I'm telling you this is we should be talking about the 2 things they intervened on in this study, which are physical activity and nutrition. Because inactivity and poor nutrition are the real epidemics in this country. Obesity is just one of the markers of it. The deeper issue is the chronic disease rates that are going to follow. So, if you don't do anything else, let me ask everybody in the room to join me on my campaign to change the conversation. Well, let me boil it down to 3 numbers. From a physical activity standpoint, I can tell you all the data in 3 numbers. 30, 23, 65. You ready for this? 30 is the minutes per day we're told every American adult should be physically active, a minimum. The dosage that was in that diabetes trial that I told you about. Remember, they were averaging just a half an hour a day of moderate walking. 20, unfortunately, is the percentage of American adults that actually get it through what we call leisure time physical activity. Constantly going for a run or a jog, going to the gym, taking a class. 1 in 5. 365, gotta guess what that is? Days of the year, so you would think. Here's the really grim picture. Add 3 zeros, and you have an estimate of the number of premature annual deaths in the United States due to physical inactivity and poor nutrition, or the so-called obesity epidemic. Let me be very clear about this. This is second only to tobacco, which kills about 400,000 Americans prematurely. Then it's inactivity and poor nutrition. And indeed, the last time they ran the data, tobacco deaths look to be flattening, while inactivity and poor nutrition deaths continue to rise. Next time they run the numbers, physical inactivity and poor nutrition will be the #1 cause of premature death in our society. And disability and disease, all the chronic diseases that lead to it. So, to be clear, the guidelines say very clearly, you don't have to be exercising. These people walking around, clearly they aren't out for an exercise walk. Gosh, they're pulling luggage, you know, or grocery carts or something over on the hillside neighborhood. But if they accumulate 30 minutes of activity, walking to and from classes over at Tufts, or to and from a train station because they're in the midst of travel, if they get 30 minutes of activity, it reduces their risk for chronic disease and early death. It doesn't have to be conscious, change your clothes, go to the gym, exercise. Are we all clear on that? It can even be broken up. So the person who does a 10-minute walk to the tea in the morning, 10 minutes strolling for errands at lunch, 10 minutes back to the tea in the evening, that 30 minutes reduces the risk for cardiovascular disease, type 2 diabetes, osteoporosis, clinical depression, dementia, and old age, a growing list of cancers. It helps you live a longer, healthier life. That's the good news. The bad news is that 20% number I told you. Here's the yellow line on this graphic that shows you the percentage getting the 30 minutes 5 days a week. The reason I show you this is to make clear one very simple thing. Look at it over the last 20 years. The line is dead flat. We've been talking about this. Guys like me out doing health promotion, health fairs and events and TV shows, DVDs. I had a show on PBS called America's Walking. To no avail, all to no avail. We have not pushed the number 1 iota by telling people to exercise. The classic exercise approach has simply not worked. By the way, there's good reason to believe that's an overestimate because it's based on telephone survey data the Centers for Disease Control collects, in which we know people tend to over-report their physical activity and even worse, they over-report their height and under-report their weight. So they tend to be taller and weigh less when we're talking on the phone. So the BMI data is probably an underestimate too. Last public health bit. This is the last piece of public health, but it gives you the important context. Why is it so resistant to change? I think it's what I call the stickiness problem. And I can show you lots of studies and we can have a whole soliloquy about this, but the short point is this. Any of the exercise interventions that do things like call people on the phone and send them email reminders and give them diaries and exercise logs and prizes like t-shirts and water bottles. Anybody here work in health promotion? Hands up if you do. Have you given away t-shirts and water bottles to encourage people to be physically active, and pedometers and baseball hats and fanny packs? We do that all the time. We do all that stuff. And you know what? The study that I'm going to show you, they did that for the 6 months, the first 6 months, and there were 3 groups in the study. All they were trying to do, by the way, was get these people to walk 40 minutes a week. 40 minutes a day. They increased their exercise minutes. But after about 6 months, it plateaued and then drops off pretty dramatically. And again, we see studies like this, where behavior change alone, simply telling the person to do the thing, eat more fruits and vegetables, get more exercise, does not stick. By the way, keep in mind, these are volunteers. These are people who signed up to be in a study. When you look at population level data, it's vastly worse. Same thing with all the weight loss research literature. What you see is early weight loss followed by regain. Even people in a program like Weight Watchers, the yellow line here, compared to a self-help program, what you see is early weight loss followed by regain. This is what I call the stickiness problem. It is persistent in the health research literature. We can talk about it to exhaustion, but I don't think you need to. I think we all accept the idea, because if you look at the national data, we've been talking about it and we haven't shifted behavior. Is everybody okay with this? Do you all accept the stickiness premise? Because if you do, we can just move on. Good. So what it means is, we now acknowledge, and this is what the CDC's grant is very much about, maybe we shouldn't just tell people to exercise. Maybe we ought to think about routine daily physical activity as a part of our daily lives. And let's not try to get people on diets. Let's try to get people eating more healthfully, because our entire food systems sort of support healthier food choices. Fair? Let's be really serious about this. Okay, so here's my summary. It's a great website at the bottom, maintained by the Robert Wood Johnson Foundation through the University of California, San Diego. If this stuff interests you, that is a great starting place if you want to see the kinds of studies, even like transportation engineering studies, wonky ones. They're available for the bibliography at that website. And those are those 5 elements I just talked about. Okay, if you really buy all of this, you still should be saying to me, is there any path forward? Do we have actual way to get to this stuff? And when we do, community workshops like these tend to lead us to 5 or 6 things. I actually published this in a journal article I was invited to do through Tufts for a journal called Childhood Obesity. So if you want to read like the nerdy detail on a lot of the references, you can get that February 2012 issue of Childhood Obesity magazine. Is a place I sort of made the argument for the first 5 of these. In that argument, I focus more on physical activity, not the nutrition. But I'm going to just share with you sort of an imaginary sort of first step for each of these that many communities like yours are embarking on. And these I've sort of tailored to my brief observations and my experience with Medford. First of all, you got to form a team around this. And I'm going to argue, if you start to think of all the people that go on the team, it gets pretty massive pretty quick, because it's not just the sort of the core group. You're going to say, well, don't we need neighborhood associations and the private sector development, and the chamber ought to be involved. Of course, all the public health and safety people, we need police and fire. If we're going to do traffic calming, the fire department needs to be involved in the conversation. I get it. Very hard to create an organizational chart where you just start with 1 or 2 groups, but by the time you add all those others, it gets out of hand. You say, what about the elected officials and the Heart Association and the Parks, Recreation, and the Trails people, and the hospitals, and the insurance organizations, and the big employers, and of course those wacky bicycle and pedestrian advocates. We know what those guys are like. They show up at every public meeting in lycra with their helmet under their arm. Okay, so there's that crowd. And that's not a very organized organizational chart. You bet all those people at the room at the same time, and it's never getting anything done. So I have found the successful communities, this is my observation from around initiatives like yours, not just Massachusetts, the Massive Motion, but around the US. They essentially form a fairly compact driving team or leadership team of about 10 members. And that's the model we're recommending. And they're across a variety of disciplines, both public and private sector, and I'll tell you 3 things to make it on my core team. 3 criteria. Number 1, you totally embrace this vision of sort of environmental and policy level change. That is to say, if anybody recommends let's do a big healthcare and give out pedometers and t-shirts, they're out. And you're gone. Leave the room right now, because we're not going to do just behavior change programs. It's about changing policy. 2, so they embrace the idea of policy level change. 2, they can work on it as part of their job. Their job portfolio allows them to spend time on this. They're not stealing time away. And number 3, they're 1 phone call or email away from the larger group. So that when you need everybody there, they can get them there. They're people with reach and influence. So it can't just be low-level folks who care about this passionately but don't have some real influence. All right, so just to recap, embrace the vision, able to spend time on it as part of their job, and community influence. The reason I'm saying this is because it could well be that some of you really should be sitting on that team that you arguably are convening as we speak. It really comes out of this work that you guys move to a compact leadership team and then the larger group. Because then the larger group is action teams around the kinds of areas that are represented by the tables, the little topics in the tables here. And the leadership team sort of acts as the nexus point to make sure we make the connections across disciplines. So as we're building, as we're prioritizing what sections of trail we build, we might want to look at our schools and say, okay, where can we help alleviate a challenge of walking and biking to school with the next mile of trail that we build, or even quarter mile, whatever it might be. Here's my concluding point. I have never seen a community where money was the reason they could or could not do this stuff. It is not about the money. This is about setting your core principles and policies and having a direction, a true north that says this is the outcome we're going to have 40 years from now. We're going to create a community where we can have free-range kids, and while they're out there free-ranging, they get to eat healthfully. And it's because we're going to do a series of things over decades to get us there, not just a nice program tomorrow. I've seen poor communities without 2 nickels to rub together do a good job of this. I've seen wealthy communities with a lot of dough do a horrible job, do nothing, sit on their hands because they think they're fine. And that means it's about vision and leadership and giving that leadership the protection, if you will, the political cover to do the right thing. And I don't mean just your elected and appointed officials, but certainly them, but also staff. Heads of public works and planning and engineering. Those folks have, in the school administration, have to be given the cover so that when they make the courageous but sometimes hard decisions, they're not alone. These are all the reasons we should do this stuff. Did you know that we kill 4,000 pedestrians in the United States every year? That closer to 40,000 die in motor vehicle crashes, but closer to, as I told you before, 400,000 due to sedentary living and poor nutrition. Let's put a scale on this when we talk to our engineering colleagues about why we have to make more walkable, bikeable streets. We can talk about our dependence on foreign oil, greenhouse gases. We can talk about all those economic incentives, like the fact that businesses now want to locate in communities where quality of life is higher, where employee retention will be higher, and where healthcare costs will be lower. That's just good business. You don't even have to do this out of altruism. It's good business
to do this. This is where the businesses are going. I know you guys are building this here. I know you're already thinking this. I see so many elements of the good work you're doing. The challenge is use this CTG grant to amp it up to the next level, to be comprehensive. Don't just have pockets of success. Say systematically, every time we think about this, we're going to keep doing this. It will be our raison d'etre. Nobody will come to Medford, whether it's somebody who owns property now or a new developer, without assuming that's what's going to be expected of them. It will be not just a public health success, it's going to be an economic success. It's going to continue to drive the good stuff you already have. By the way, I am a raving froth-at-the-mouth lunatic about this stuff. Quite frankly, not for that guy, not for myself, my dire cat, and not for any of you who seem like very nice people, but who, honestly, I don't care a whit about. I don't. You're nice people, but I don't care. Who's it for? It is. It's for the kids. My kids, I told you I'm 14 and 16, but I've frozen them in time at 3 and 5, as you can see right here, because they were so cute back then. Honestly, it's to remind myself of this very disturbing reality. They are part of the first generation that is going to end up with shorter life expectancies than their parents. That generation of kids will end up, because of, we expect 1 in 3 of them to get type 2 diabetes in their lifetimes. I mean, it is mind-boggling the public health uphill battle we face with this generation and succeeding generations if we keep doing what we're doing right now. And here's the problem. We know what the problem is, and it's not just telling people to exercise and eat better. There are these environmental determinants of health. We know what they are, and we know the solutions. We've just talked it through. It may seem like I was a little pedantic to do 1, 2, 3, 4. Frankly, we've got to have checklists, and we've got to start to think about this stuff this way. We can. And that's why I appreciate you guys being here, because you'll be part of it. So thank you so much for your attention on this. I really